You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for February 2nd, 2024. Today, pulse field ablation, approved for use in AF ablation in the U.S., flawed comparisons of transcutaneous edge-to-edge repair versus mitral valve surgery, and flawed comparisons of PCI versus CABG, and finally, cardiologists are struggling with board exams. First, I want to thank my friend, Dr. Rod Tung, and colleagues at the University of Arizona for the kind invitation and reception in Phoenix when I gave cardiology rounds last week. I had a great time presenting controversial topics to young learners, and I appreciate these trips very much, so thank you. All right, first topic is that the FDA has okayed Boston Scientific PFA, pulse field ablation system, for the treatment of paroxysmal AFib. Now, I realize many listeners are not EP docs, so I'll try to keep everyone interested. You all do know about AF ablation and how modest our success rates are. You also surely see advertisements for this new, quote, breakthrough in AF ablations, and I'm going to try and give you the neutral Martian take. This is a fun story for me because the announcement came right before an AF symposium in Boston. And I used to go to this Boston AFib symposium way back before I met Nasir Marouche and switched my AFib meeting over to Western AFib. Now, note to fellows who listen, nearly every procedure I do now did not exist when I trained, so I had to go to conferences like Boston AFib to learn to do ablation of AF because it didn't exist when I was in training, and it'll likely be the same for you as well. So the things you're learning now may not happen, and you may need to go to symposiums. But the thing I remember most about Boston AFib back in the early days of AF ablation is that there was always these promises of breakthroughs. Something would come up, a cryo balloon, lasers, rotor mappers, and each of these new techniques had their enthusiastic promoters. But none of these next big things panned out. 20 years on, we're still just isolating pulmonary veins and not knowing whether it is the right geography to ablate. This week, the FDA cleared the Boston Scientific Pulse Field Ablation, or PFA system, for the electrical isolation of pulmonary veins for AF ablation. The system goes by the name FARAPulse, and it is the second PFA system approved, as the Medtronic PFA system was approved in late 2023. Now, most of my American colleagues are very excited about this new way to destroy left atrial myocardium. Yet, I am skeptical, and I'm not sure this is going to be much of an advance for the field of EP. Now, as I speak, though, I will have in my mind that clinicians whom I have immense respect for in Germany, in Denmark, France, and the UK have used the PFA system, and they seem pretty positive about it. So let's start with the PFA advantages. First is safety, right? PFA is electrical therapy. The catheters deliver electrical energy, aka shocks, to the atrial tissue. That kills myocytes with a process called electroporation, meaning the shock creates pores in the myocardium. But it has to be the Goldilocks amount of electroporation, just enough to achieve irreversible electroporation, but not too much to cause damage to the outside structures via thermal energy. In other words, when the dose, and perhaps the catheter contact is just right of the electrical energy, you get irreversibly dead myocytes, but no other damage. PFA is billed as cardioselective. This is because the electrical therapy requires ion channels, so surrounding areas like the nerve, endosophagus, and pulmonary veins are not supposed to be affected by PFA. Proponents of PFA say that the non-thermal energy is safer because there is less chance of non-cardiac damage. Now, non-cardiac damage is a bit of a euphemism. What that means, actually, is that PFA may be able to avoid two super scary complications of AF ablations. One is phrenic nerve injury, wherein the diaphragm is paralyzed, and esophageal injury and death from AE fistula, atrial esophageal fistula. The challenge is that these are difficult things to show empirically. For instance, in the ADVENT trial, which was the U.S. regulatory trial published in November in New England Journal of Medicine, comparing PFA and thermal AF ablation with either cryo or RF, there actually were some cases of phrenic nerve injury in the PFA arm, though they were not permanent. This makes me wonder whether PFA is actually as non-thermal as is advertised. Now, the challenge in showing that PFA does not injure the esophagus and cause death via AE fistula is even harder to show because this complication is so darn rare, probably in the order of 1 in 1,000 to 1 in 10,000 with standard thermal ablation. So, no, there have been no reports that I know of AE fistula with PFA, but since the complication is so rare, any putative safety benefits with PFA are going to be speculative. Now, I'll come back to safety in a second. Another advantage of PFA, my European friends say, is that PFA is fast. In big PFA centers, they can do AF ablation in like 40 minutes. Right now, after 20 years, I average around 75 to 90 minutes for an RF ablation of AF. The FDA regulatory trial for PFA was called ADVENT, and I'll link to it. It was published in New England Journal in November. This was a comparison between PFA and thermal ablation. The thing was, at least in the U.S., the time of ablation was 105 minutes in the PFA arm and 123 for thermal. So it was faster, but not by much, and it was a lot longer than Europeans can do it. So Americans can't seem to replicate European procedure times. Now, I think it's going to get faster in U.S. centers, but because we don't have the same cost constraints, I suspect we will never be as Euro-fast because we just have to put extra catheters into the heart to do pre- and post-ablation mapping, and the culture of AF ablation is just different here in the U.S. Now, the actual empirical data for PFA efficacy is that it is quite similar to thermal ablation for efficacy. In ADVENT, the primary endpoint was basically AF recurrences, and the Kaplan-Meier curves are near identical. So it's not like PFA is any better than thermal ablation. And complications from ADVENT trial are worth noting. PFA associates with some of the same complications as thermal ablation. Things like cardiac tamponade due to perforation, stroke, and vascular access issues. ADVENT randomized about 300 patients per arm, and there was actually one death in the PFA arm. This was due to pericardial tamponade, and the authors write that the death did not seem to associate with any of the specific PFA issues. But still, one death, PFA arm. Typical AF ablation complications with PFA have also been shown in observational data from Europe. My friend Stefano Bordignon put together the most recent and largest PFA registry, published in EuroPace last summer. This data found that PFA can cause many of the same complications as thermal ablation. Things like perforation of the heart and cardiac tamponade, and sadly stroke too. This paper also noted stroke in 5 of 1,200 patients. I specifically worry about the stroke issue because PFA causes intense microbubble formation in the LA. Along with Dr. David Tomlinson from the UK, I wrote an editorial on one of the early PFA papers called Persistent AFib 1 in 2020, and I'll link to that editorial. We expressed concern over the relatively small numbers of cerebral MRI scans that were done in PFA groups. Most recently, a large observational study called Manifest reported on 17,000 patients who had PFA. It has been presented at AHA but not yet published. At least I don't know of the publication. This large study reported many of the same complications, but also a new complication has emerged. It is actually hemolysis-related renal failure requiring dialysis in 5 cases. I also found a case report of this as well. Now, the idea here is that if you do too many electrical shock deliveries, and these shocks are with catheters without great contact, you may be basically shredding RBCs in the blood pool. This is all a theory of why it happens, but it does happen. Now, the proponents of PFA have an answer to this. Just make sure to hydrate your patient with IV fluids. And that solution makes me grin because one of the nice advantages of late, one that allows for same-day discharge after ablation, is a new saline irrigated catheter that really requires a lot less saline irrigation. It's an advance because in the old days, patients who had AF ablation used to get tons of volume and IV fluids, and they got fluid overloaded and required IV diuretics. And now the fluid load with AF ablation is minimal. Okay, PFA also comes with some practical limitations. When used close to a coronary artery, it can cause coronary spasm, requiring angiography and intracoronary nitroglycerin. I don't know about your lab, but mine is not so easy to do coronary angiography in, and I haven't used a manifold in 20 years. Most EP operators will not use PFA to ablate common arrhythmias that accompany AF, such as cavotricuspid or mitral isthmus flutters or SVTs. And of course, if you have to open another ablation catheter during the procedure, there are no cost savings. In sum, I'm going to withhold final judgment until I see how PFA iterates and how the coming months and years look. I certainly won't be an early adopter of this new way to isolate pulmonary veins. But I'm not totally negative on this because there are just too many colleagues who I respect who use PFA. But in the end, sadly, it is just another way to create scar in the left atrium. To really advance the field of EP and AF care, what we need is not better tools to ablate, but more knowledge about what actually causes AFib. All right, second topic, mitral valve surgery or transcutaneous edge-to-edge repair, otherwise known as mitral valve clipping. The European Heart Journal has published a paper in January from French authors that compared outcomes in patients who have either open heart surgery or mitral valve clipping for severe mitral regurgitation. Now, this is becoming an important question because TEER, transcutaneous edge-to-edge repair, is actually getting better. The procedure has iterated since its approval for primary MR many years ago, but surgical repair or valve replacement has been a far more tried and true intervention. Now, regular listeners ought to be thinking what comes next, right? This is, if you want to know how these procedures compare, there is only one way, an RCT. I hope regular listeners will know that randomization is absolutely critical because it's the best way, perhaps only way, to balance the known and unknown patient characteristics. Sadly, this is not what the French team did. Instead, they used a database, one that is a lot like a Medicare database. Now, they had 57,000 patients in this database of patients who had treatment for mitral regurgitation. But about 52,000 had mitral surgery, and about 2,000 had edge-to-edge repair. Now, just pause there. 52,000 versus 2,000. And in the unmatched comparisons, all-cause death for the surgery group was 6% per year versus 18% per year in the edge-to-edge repair group. And the same proportions were seen with CV death. Death rates were nearly double for the edge-to-edge repair group. The reason is obvious, right? Sicker, older patients get edge-to-edge repair. Now, the authors of this paper's solution to the problem is to do propensity matching, wherein they take 2,100 patients from that big pot of 52,000 surgical patients who are most like those who had edge-to-edge repair and then compare outcomes. I hesitate here to even tell you the results because this is a fatally flawed way to study outcomes. But since the paper made news, I will tell you. All-cause death was the same, no difference. But edge-to-edge repair was associated with a significantly lower incidence of CV death. The hazard ratio was 0.68, so a significant reduction. Edge-to-edge repair was also associated with less pacemaker implantation, and stroke. However, non-cardiovascular death hazard ratio was higher for edge-to-edge repair, as was recurrent pulmonary edema and cardiac arrest. The authors concluded, quote, "Our results suggest that edge-to-edge repair for severe MR was associated with lower CV mortality than mitral surgery at long-term follow-up. Pacemaker implantation and stroke were less frequently observed after edge-to-edge repair." My comments. I do not like this study. Not at all. I don't even think it should have been done or published, and I mean no malice to the authors personally. Please. My reason to not like this is that the methods like propensity matching are too unreliable. I've said this many times on this podcast, but matching techniques can only match on the basis of things in a spreadsheet. When a clinician at the bedside recommends one of two therapies, she or he is going to use a lot of factors to decide, and many of those factors can't be put in a database. And to make matters worse here, it is obvious from the unmatched data that these are vastly different types of patients, so already it seems impossible to match patients. Another problem with the paper is that mitral repair is mixed in with mitral replacement. Finally, I am also critical of the peer reviewers and editors for letting such a biased conclusion come through. Why not report the lack of difference in total mortality? And of course, everyone knows pacemaker implantation is going to be more after surgery. The conclusion, I'm afraid, very much provides momentum for structural cardiologists and those that do transcutaneous edge-to-edge repair. And edge-to-edge repair may be great for some patients. It surely is. But the only way to compare the two strategies is to let randomization choose the procedure and then measure unbiased outcomes after a few years, like what was done mostly in the TAVI versus SAVR trials. Unfortunately, I've read that there are RCTs ongoing in this space. And finally, my concern about this paper transcends the treatment of just mitral valve disease. When authors are allowed to publish flawed analyses and then make these biased conclusions, trust in medical science goes down. The authors so much as write that their conclusions, quote, may not be fully appropriate deep down in the limitation sections. My question is, if that's true, why do such a study and why make such outsized conclusions? All right, next topic, ischemia trial post-hoc studies. The lead article sitting on the JACC website this morning, right now, is a post-hoc study from the ischemia authors. And I do like the ischemia trial. You remember it, right? Patients who had positive stress tests were randomized after a blinded CTA scan excluded left main disease to either an invasive strategy wherein they got angiography and revascularization if the doctor felt it appropriate, or they were randomized to a conservative strategy of tablets and angiography and revascularization only if they had recurrent symptoms, and the results for major adverse outcomes were not different at 3 years. And what I loved most about the ischemia trial was the graph in the supplement that showed that the conservative arm achieved the same results with like 70% fewer angiograms and revascularization. Now, while this data seems to have little difference in rejecting the clogged pipe frame of stable coronary disease, I find the results extremely useful because it reinforces the idea that stable coronary disease, even that which causes severe ischemia on stress testing, is quite stable and can be treated with a conservative strategy initially. It blows up the idea that all positive stress tests have to go to the cath lab. Now, the problem I'm seeing lately is that the ischemia authors continue to publish confusing and less than useful post-hoc studies. The latest one has taken me hours to sort out. The idea was here to focus on early and late overall risk that associated with each of the coronary revascularization strategies in the trial. But the inherent problem is it's similar to the edge-to-edge repair versus mitral surgery study I just talked about. That is, while ischemia was a randomized controlled trial, the choice between PCI or CABG was a clinician's choice. That choice wasn't random. And in ischemia, about 1,500 patients were revascularized with PCI, about 530 with CABG. So comparing them is basically an observational, non-randomized effort. This paper had two analyses. One was to form four groups, right? So one group was an invasive medical group. Those enrolled in the early invasive arm but had medical treatment. Another was invasive PCI, and another was invasive CABG, and then the control arm was the conservative arm. The second analysis was to look at outcomes after PCI or CABG regardless of their assigned group. Once again, I even hesitate to tell you the results because these observational non-random comparisons are likely to be biased. But since it's in JACC, I will tell you the results and then why it is so problematic. In fact, the central illustration in this paper includes one of the most ridiculous Kaplan-Meier curves I've seen. So if you look at the four groups, invasive PCI, invasive CABG, invasive medically treated, and conservative, the invasive CABG arm starts out with a huge increase in MACE events early because of periprocedural biomarker evidence of periprocedural MI. Then the curves basically are parallel, though surgery ends up a bit higher in the end, more outcome events, solely because it started higher because of periprocedural biomarkers. But it's a useless comparison because if you measure biomarkers and call this an MI, you're going to always bias against CABG. The curves that look at death, CV death, and stroke curves of these four groups are the same. So my comments. I'm not sure why the authors did this study. It's all observational. Clinician choice between CABG and PCI will be affected by multiple factors. So looking at outcomes here after each of these is almost worthless. What's more, the periprocedural MI definition using biomarkers is clearly a flawed way to look at outcomes because it biases against CABG. And we already have RCTs of PCI versus CABG in patients with multivessel disease. I mean, just recently, FAME-3 showed that even FFR-guided PCI did not reach non-inferiority against bypass surgery. I just don't see this as a helpful analysis. I mean, compare it to the COURAGE authors. The COURAGE authors did many post-hoc studies. Most of these studies chronicled their search for subgroups that would benefit from PCI plus medicines. None of these sub-studies found such a group. Now, maybe it's my bias, but I find these sorts of sub-studies useful because they lend strong support to the primary analysis. For instance, there's even a sub-study that shows that even patients with the LAD widowmaker did not benefit from PCI over medical therapy. The overall results of the ISCHEMIA trial have been extremely helpful. Its post-hoc analyses, though, not so much. So also, let me add, please, friends, if I'm wrong about this, point me to an unbiased, clinically useful ischemia post-hoc study. I'm willing to learn. All right, final topic today is that new cardiologists seem to be failing the cardiology board exams. The Heart.org Medscape Cardiology has a news article about a recent report from the American Board of Internal Medicine that notes an increasing failure rate for the CV board exam. The pass rate for first-time takers has dropped in the last 2 years to 86%, which is pretty sobering because if more than 1 in 10 future cardiologists can't pass the initial board exam, that seems like a problem. Now, of course, I have mixed feelings about this observation. On the one hand, the old man, I walk through 6 inches of snow barefoot kind of thinking goes something like this. It's like, come on, you all, what are you doing during fellowship? Maybe worry a little bit less about measuring the left atrial appendage before appendage closure and study some basic cardiology. But my complete response hopefully will be more nuanced than that. But there is something to say about the idea that becoming a cardiologist requires knowing a lot of stuff, at least initially. I mean, okay, I studied a lot in fellowship, a real lot. And I remember last year spending an entire week and weekend relearning pressure volume loops so I could speak quasi-intelligently about heart rate issues in HFpEF. So cardiology fellowship, it seems to me, a great time to read less Twitter and maybe more cardiology textbooks. But let me say, I am no fan of ABIM or ABIM test questions. Always remember that board exams are a mere surrogate marker for good care. What medical training is supposed to do is to create competent caregivers. The endpoint is not a test score, but good bedside care. and I'm growing increasingly confident that repeated maintenance of certification, MOC efforts from ABIM are not at all beneficial in achieving the goal of making better clinicians. While first-time exams are a bit isolated from the maintenance of certification argument, I'm certain that some of the material I routinely present when I give cardiology grand rounds would harm board scores. For instance, I'm sure some of the right answers on many cardiology board questions is sacubitril valsartan, cardiomems, left atrial appendage occlusion, and coronary calcium scans. The material I show learners from the seminal trials would make them question these commonly accepted right answers. I call this the Christopher Hitchens problem of test taking. The late writer and intellectual famously became an American citizen and wrote that he struggled with the citizenship exam because his rigorous study of American history led him to believe that many of the commonly accepted ideas were not grounded in a careful read of the original text. And finally, I'm not sure that the failure rates do not implicate the exam. I would not leap to the conclusion that it must be the fellows and not the exam. One of the commenters in the news article notes that the exam has not changed much in the past 6 years. Well, maybe the exam does need to change. Cardiology has surely changed, so maybe the exam should as well. For instance, one change that I've noted in the last 5 to 10 years is that my biggest challenge is not having something to do, but whether I should do it in the first place. The bottom line is that most would agree that there should be some measure of first-time competence coming out of fellowship. Measuring that competence will surely be flawed because I have seen great test takers be not so good at doctoring and vice versa. This one is a tough topic, so please let me know what you think about this. I'm willing to learn. I don't really have the obvious answer because I don't think there is an obvious answer. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, friends, if you like this podcast, please take the time to give us a rating on whatever app you use. Or if you disagree, please go to the website, write a comment, write a review, tweet to me. Let me know. I'm learning from my listeners all the time. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.